Hi everyone, welcome to Capstone. My name is lmastel and I will be doing your microbiology review today. Thank you for spending your day with me. I did put the video on so you could see who's behind the voice that you're going to be listening to for the next couple of hours. But I will turn it off now because I have a tendency when I look at WIMBA sessions to pay attention to the video, and I think it's very important that you are paying attention to each slide that I am presenting to you today. So I will shut off the video camera for now and we will get started. Have a good day. Thanks for joining me. Okay. A quick review of the culture process. A culture starts when the physician orders a culture of a specimen. The specimen is collected and received in the laboratory, and then it is reviewed for acceptability. The specimen is then plated to the appropriate media depending upon your laboratory's protocol. If the culture grows, biochemical testing is performed on the culture, and then antibiotic susceptibility testing is then performed if needed. All right, here's a review of normal flora. In the skin, we see Candida, Micrococcus, Staph, and Diphtheroids. The Diphtheroid species can include Corynebacterium as well as Propionibacterium species. In the GI tract, we see anaerobes such as Bacteroides, Clostridium, and Fusobacterium, as well as members of Enterobacteriaceae such as Proteus and E. coli. And then we can also see Staph aureus and Enterococcus. In the upper respiratory tract, we can see various members of staph, diphtheroids, Haemophilus parainfluenzae, and alpha streps. In the female genital tract, we might see Lactobacillus, Bacteroides, staph, Enterococcus, diphtheroids, group B strep, and Candida albicans. And finally, in the mouth, we might see staph, alpha streps, Lactobacillus, and Peptostreptococcus. It's very important to keep in mind when you are screening for pathogens that you note where normal flora is normally located and that you are able to decipher between normal flora and pathogen. It is also important to note that if you do not see normal flora in a site that should have normal flora, this should be documented. Sometimes we have pathogens that can overtake the normal flora and overgrow them, and so if you have a GI tract specimen that you can only see one colony type in, this is probably meaning that the normal flora have been overgrown or have been wiped out, and we have a pathogen that is overgrowing. Okay, collection of specimens in the laboratory. I will be going over some of the more common specimens that you will encounter in the lab. Keep in mind that microbiology cultures can pretty much be taken from anywhere and everywhere. First, we have a throat specimen. This is collected on a swab containing Stewart's or Amy's media. It's usually not gram-stained, and it is plated to blood agar. Common pathogens screened for in throat swabs include strep pyogenes or group A strep. The nasopharynx is also collected on a swab containing Stewart's or Amy's media. It's usually not gram-stained. It's plated to chocolate and blood agar, and common pathogens that we screen for are Corynebacterium diphtheriae, Bordetella pertussis, and Neisseria meningitis. A sputum specimen is collected into a sterile container, and it should be gram-stained to determine acceptability. If we see too many epithelial cells in a sputum specimen, this indicates contamination from the mouth, and we would want to call up to the physician or to the nurse and tell them that a new specimen needs to be collected. Generally, if you see greater than 25 epithelial cells in a sputum specimen, you should reject it. A sputum is then plated to chocolate, blood agar, and McConkey's, and it is screened for common pathogens such as strep pneumoniae, Haemophilus influenzae, and Pseudomonas aeruginosa. Stool specimens are collected in a sterile container, and these are not gram-stained. The reason a stool specimen is not gram-stained is because stool contains many different types of normal flora, and so if you're going to gram-stain it, you're going to see all these normal flora bacteria popping up, and it's very difficult to distinguish what could be pathogen and what isn't. So we usually do not gram-stain a stool specimen. The specimen is plated to blood agar, McConkey, XLD or HE, Sorbitol McConkey's, and Campi. And common pathogens that we screen for in a stool specimen include Salmonella and Shigella, Campylobacter, and E. coli 0157H7. A urine specimen is collected in a sterile container, and this one is also not gram stained. Media it is plated to then include blood agar and MacConkey. And there are many, many different types of bacteria that can be isolated from a urine specimen. I've just listed a couple here, including members of Enterobacteriaceae and also Staph saprophyticus. Blood is collected into blood culture bottles. It is very important that you're collecting a blood culture specimen to maintain aseptic technique because you can get the normal flora from the skin contaminating the blood culture bottles. If the blood culture bottle does come up positive, it is gram stained, and then it is plated to chocolate, blood agar, MacConkeys, and anaerobic media. Common pathogens seen in blood include members of Enterobacteriaceae, Staph aureus, and Strep pneumoniae. Cerebrospinal fluid specimens are collected into a sterile container. These are gram stained, and CSFs are usually always stat. They are then plated to chocolate and blood agar. Common pathogens that we see are Haemophilus influenzae, Neisseria meningitidis, Strep pneumoniae, Strep agalactiae, and Listeria monocytogenes. Aspirates from an abscess are collected into an anaerobic transport media. They are gram stained, and then they are plated to chocolate, blood agar, MacConkey, and an anaerobic media according to laboratory protocol. And then common pathogens that might be found in an abscess include Staph aureus, members of Enterobacteriaceae, and various types of anaerobes. And finally, we have genital tract specimens. These are collected on a swab containing Stewart's or Amy's media. They are gram stained, and then they are plated to chocolate, blood agar, and Thayer-Martin. Common pathogens that we might see in a genital tract specimen include Neisseria gonorrhea, Gardnerella, molgus, Candida albicans, and Haemophilus ducreyi. Now keep in mind the specimen collection criteria that I have listed here for you come from your textbook. When you are in your laboratory, follow your own laboratory's protocol to what media you're going to be plating them to, whether it's gram stain or not, and what you're going to be screening for. Cerebrospinal fluid specimens are usually always stat. These are kept at room temperature. Body fluid cultures and blood cultures are set up as soon as they are received. And then other specimens such as abscesses, throat, nasopharynx, sputum, and genital tract specimens are kept at room temperature. And then stool and urine are usually refrigerated. Sputum specimens might also be refrigerated prior to culture. It just depends upon when it was collected and when they're going to be able to plate it. Again, this is another one of those slides where follow your laboratory's protocol. All right, moving on to a media review. On the left-hand side, you see MacConkey agar. MacConkey agar is selective and differential. It is selective for gram-neg rods, and it is differential because you can see the different colony types. They are lactose fermenters if they turn up pink, and they are non-lactose fermenters if they turn up clear. On the right-hand side, we have blood agar, and you can see that blood agar is differential because it shows up various types of hemolysis. We have our alpha, gamma, and beta hemolysis, all which can be seen on this plate. Letter A, it's kind of hard to see, but that one is a alpha hemolytic colony. B is a gamma hemolytic colony, and then C and D are various levels of beta hemolysis. All right, our blood agar plate ingredients include tryptase soy agar base with 5% sheep blood. The purpose is to support growth of most microorganisms and to determine hemolysis. Organisms isolated from blood agar include Staph aureus, Strep pyogenes, E. coli, and Pseudomonas aeruginosa. Our agar is similar to blood agar, but the red blood cells are lysed in order to release the X and the V factor. Remember that X is your hemin and V is your NAD. And chocolate is used to support the growth of fastidious or picky organisms. These include Haemophilus and Neisseria species. McConkey agar has a peptone base. It contains lactose, crystal vial salts, and neutral red. It does only grow gram-neg rods, and it is to determine lactose fermentation. Again, we talked about how the lactose fermentators turn pink and the non-lactose fermentators are clear. Some organisms isolated include E. coli, Pseudomonas aeruginosa, Proteus mirabilis, and Klebsiella pneumoniae. All right, then we have CNA. This has a Columbia agar, and it includes colistin, nalidixic acid, and a 5% sheep blood within the agar. It supports the growth of Gram-Pos cocci. Common organisms isolated from CNA include Staph aureus, Strep pyogenes, and Enterococcus species. Then we have PEA, which is similar to CNA in that it supports the growth of Gram-Pos cocci, but PEA contains a nutrient agar base and phenylethanol. And again, you can see that it grows Staph aureus, Strep pyogenes, and Enterococcus. Then we have EMB, eosin methyl blue agar. This has a peptone base with lactose, sucrose, and eosin methylene blue in it. This supports the growth of gram-neg rods and can also help to determine whether a colony is lactose fermenting or not. Gram-neg rods grow on this, and these include E. coli, Pseudomonas aeruginosa, Proteus mirabilis, and Klebsiella pneumoniae. Next, we have mannitol salt agar. This has a peptone base, a phenol red indicator, and consists of a high content of salt at 7.5%. This agar is used as a selective isolation tool for staph species. We can grow Staph aureus, Staph saprophyticus, and Staph epidermidis on. What Staph aureus will do is it will raise that indicator to a yellow color, and so the Staph aureus colonies will grow yellow, whereas most of the other Staph colonies will grow a red color. Bismuth sulfite agar contains casein, dextrose, ferrous sulfate, bismuth sulfite as an indicator, and brilliant green. This one is selective for salmon species, and an example of a salmonella species that would grow in there would be Salmonella typhi. Then we have TCBS agar. This one contains peptone, biosalt citrate, sucrose, ferric citrate, sodium thiosulfate, and a bromthymol blue. And this is selective and differential for Vibrio species. So organisms such as Vibrio cholera will grow this agar. Okay, next we have Thayer-Martin agar. This one is a blood agar base, and it contains antibiotics colistin, nystatin, vancomycin, and trimethylprim. The purpose of this agar is to isolate Neisseria gonorrhea and Neisseria meningitidis. And the various antibiotics that are included in this agar help to minimize the growth of other things such as yeast, other Gram-Pos cocci, other gram-neg rods, and swarming Proteus. Cappy blood agar contains a Brucella agar base, sheep blood, and then various antibiotics such as vancomycin, trimethylprim, polymyxin B, amphotericin, and cefin. And this one is used to selectively isolate Campylobacter species such as Campylobacter jejuni. And the purpose of all those antibiotics is to inhibit the growth of other bacteria from overtaking that Campylobacter species. And finally, we have BCYE agar. This contains a yeast extract, charcoal, and L-cysteine. This one is selective for the isolation of Legionella species such as Legionella pneumophila. Okay, once our media is plated, we got to figure out what to do with it. Where are we going to incubate it? So most of our media is incubated at 35 to 37 degrees Celsius. There are some exceptions for pathogens. If you're looking for Campylobacter jejuni, this one is incubated at 42 degrees Celsius. It likes a little bit warmer temperatures. If you're looking for Listeria monocytogenes and Yersinia enterocolitica, these ones actually like refrigerator temperatures a little bit better. They like the cold. So you would incubate them at 20 to 40 degrees Celsius. Usually bacteria like to grow in a moist environment, so the humidity is kept to a higher level. And then another thing that you want to determine is, are you looking for an aerobe, an anaerobe, or a capnophile? If you're looking for an aerobe, you want to put them in an environment that contains oxygen. However, if you're looking for an anaerobe, you don't want them to be exposed to oxygen at all. So you need to have some sort of system that's going to get oxygen out. And then finally, if you're looking for a capnophile, if you remember, these organisms like an increased amount of carbon dioxide. So that has to be kept in mind as well when you are determining whether to incubate. And again, each laboratory is going to have their own protocols for where you're going to be incubating each plate, depending upon where it came from. All right, just a quick review of specimen rejection criteria. If the label and the requisition don't match, you need to figure out where the discrepancy is and either solve it or reject the specimen. If the specimen has been improperly transported, then that needs to be rejected. Let's say a CSF was put in the freezer, you would want to reject that because it needs to be kept at room temperature. If an inappropriate media was used, such as an aspirate was collected and it was put into an aerobic media, it would be unacceptable for an anaerobic type culture. If there's not enough specimen, you would cue it saying quantity not sufficient. We need to obtain more specimen in order to get accurate results. If the specimen was leaking, this is very common with urine specimens. If the cover wasn't on all the way, then half the urine leaks out into the bag. Technically, that specimen is no longer considered sterile, and so you would probably want to reject that. If the specimen is older than 2 hours, this is another example of a urine culture. If you've got that specimen sitting out at room temp for greater than 2 hours, more than likely you have bacteria in there from the skin that are going to be multiplying and will probably give you incorrect results. So you probably would want to reject that specimen. If you have a specimen that is received in a fixative, sometimes tissue samples may be collected and put into a formalin fixative. These would be unacceptable for culture because formalin is going to kill off any kind of living organism that would be present in that culture. So you would need to reject that specimen and have the physician or nurse recollect. If you have an anaerobic culture that's been ordered on an anaerobic site, that should actually be aerobic site, not anaerobic site. If you have an anaerobic culture that's ordered on an aerobic site, then you would want to reject it. So if somebody ordered a throat specimen as an anaerobic culture, obviously that's been exposed to air, you would want to reject that specimen. And then if you have a specimen that's been dried up, probably want to get a new one. The last one there says questionable medical value if worked up. An example of this would be if you've got blood cultures that were collected and you find one bottle that was positive as a blood culture and it comes back as coag-neg staph. This can be questionable because it might be a contaminant. So in that case, you might want to reject the specimen. It does depend upon your protocol again. And then another one would be if you've got greater than 3 colony types in a urine, you wouldn't want to work that specimen up because that probably considers contamination. One thing that I want to mention on this slide that's very, very important is do not reject a specimen without notifying the physician first. There are some situations where even though it was collected improperly or it wasn't labeled correctly or whatever the case might be, the physician still wants to run the specimen even after you say, well, you know, it doesn't match our criteria for setting up or so-and-so is wrong with it. It ultimately is up to the physician on whether to run that specimen. So do not reject anything without first notifying somebody that you are going to reject it first. Okay, we're moving on to Grandpa's cocci. All right, what I have done for you is I have broken down the organisms into gram stain, And then I have broken them down into the types of infections they cause, what lab tests we would use to identify each one, and then whether antibiotic susceptibility would be needed. Again, keep in mind that the susceptibility and lab tests for ID are going to depend upon the laboratory that you work at, so you're always going to follow your lab protocol. However, these are the more common tests that would be done on these organisms, and common board questions can arise from these as well, so I would recommend that you study these. Okay, first we have Staph aureus. Types of infections caused by Staph aureus include impetigo, wound infection, scalded skin syndrome, toxic shock syndrome, and food poisoning. The colony appears often as a creamy beta hemolytic colony on blood agar. It is catalase positive, coagulase positive, and there are latex agglutination tests available for Staph aureus as well. Antibiotic susceptibility is warranted because MRSA or methicillin-resistant Staph aureus has become more and more common. Staph epidermidis is known to cause nosocomial bacteremia, usually involving some sort of catheter. On blood agar, it appears as a gray-white sticky colony. It is catalase positive, but it is coagulase negative, and it is sensitive to novabiocin. When doing susceptibility on Staph epidermidis, you want to establish clinical significance before testing. This would be an example of finding that one positive blood culture bottle with Staph epi in it. Is that really clinically significant? Probably not, so susceptibility wouldn't be warranted. All right, Staph saprophyticus. This one causes UTI in sexually active females. It really doesn't cause infection outside of the urinary tract. If it does, it's very rare. This colony appears as a white colony on blood agar. It is catalase positive and coagulase negative, just like Staph epi. However, Staph saprophyticus is resistant to novabiocin. And again, you would want to establish clinical significance for testing. Next, we have our streps. We have strep pyogenes, which is also known as group A strep. Strep pyogenes is the common cause of sore throat or acute pharyngitis. It can also cause impetigo, scarlet fever, rheumatic fever, and acute glomerulonephritis. On agar, it appears as a clear beta hemolytic colony. It is catalase negative, sensitive to bacitracin, and you can also do rapid testing on this one as well. Susceptibility is not needed for strep pyogenes as this bacteria is susceptible to penicillin, and this is the drug of choice. Strep agalactiae, or group B strep, commonly causes neonatal meningitis. It can be normal flora in the female genital tract, and so most of the prenatal specimens or patients, the specimens are screened for group B before delivery to see if there is normal flora there or not of the group B strep. Okay, lab tests for ID include catalase negative, CAMP positive, and hippurate hydrolysis positive. On blood agar, group A and group B strep look very similar, so this one is again going to be a clear beta hemolytic colony. Strep pyogenes tends to produce a larger zone of beta hemolysis than strep agalactiae does. And susceptibility usually is not needed as some sort of beta lactam is used. And finally, we have strep pneumoniae. This one causes sinusitis, otitis media, pneumonia, and can cause meningitis. This is an alpha hemolytic colony on blood agar. It may look like a little donut or a dip-shaped, so they call them coiny dips. They are catalase negative, they are sensitive to opticin, and they are biosolubility positive. And antibiotic susceptibility is needed for this one, as this organism can be resistant to many types of antibiotics. Next, we have Enterococcus. Enterococcus commonly causes nosocomial infections as well as urinary and wound infections. It may cause endocarditis as well. On blood agar, it appears a white colony with gray disappearing borders. It can be alpha, beta, or gamma hemolytic. It is catalase weak positive. If you hold an Enterococcus colony into a catalase reagent, you will see a little bit of bubbling. It's a delayed bubbling, but you will see it Now, in your textbook, they do call this as a negative reaction, even if there are a few bubbles. So, again, whether you're calling it catalase negative or catalase weak positive is going to depend upon what your laboratory uses. Enterococcus species are PYR positive. They are bile-esculin and NaCl positive as well. And antibiotic susceptibility is needed because vancomycin-resistant enterococcus species have been noted. Enterococcus causes rare infections in humans. On blood agar, it appears as a yellow colony, and it is catalase positive and microdase positive. The microdase test is a modified type of oxidase test. This is how you can tell the difference between a micrococcus and a staph, because micrococcus and staph are both catalase positive. No guidelines have been established for susceptibility because the infections are rare in humans. Leukonostoc is an opportunistic type bacteria. It can be alpha or gamma hemolytic. It produces gas in an MRS broth. And the big thing to note about leukonostoc is it is naturally resistant to vancomycin. This is a board question that might come up. So that's the big note about leukonostoc, is it's naturally resistant to the vancomycin. And again, no guidelines have been established as far as antibiotic susceptibility because leukonostoc is often considered a contaminant. All right, let's move on to members of Enterobacteriaceae, our gram-neg rods. So hopefully you remember why the members of Enterobacteriaceae are included in this group. They do share some common characteristics, and these characteristics include they are all gram-neg rods, they all grow in MacConkey's, they all ferment glucose, they are all oxidase negative, and most of them reduce nitrates to nitrite. All right, first we have Citrobacter. Citrobacter causes nosocomial infections in the respiratory tract. It can cause UTIs, blood infections, and infections in other sterile sites. It is a late lactose fermenter, and it may produce H2S. And other biochemical tests are used to detect Citrobacter. This is going to depend upon your laboratory protocol. When I list other biochemicals here, most of the time what members of Enterobacteriaceae have for ID is they are put onto some sort of automatic analyzer that does a slew of biochemical testing and then comes up with the result of 99.1% positive it's Citrobacter something. So that's kind of how Enterobacteriaceae are identified. Some of the organisms, such as E. coli, might have a quick way of testing for it, such as a spot indole or things like that nature. So again, keep in mind this is probably going to be different depending upon what laboratory you work at. Antibiotic susceptibility is needed for members of Enterobacteriaceae. E. coli also likes to cause nosocomial infections. It is the #1 cause of UTIs, and it can cause diarrhea. Lactose fermenter, it is K/A or A/A with or without gas on TSI. K/A is a red over yellow versus A/A, which is a yellow over yellow. Without gas or with gas, remember when you're looking for gas in the TSI, you're going to be looking for bubbles or cracks in the media. And then on LAA, it appears as a K/A, which is a yellow over purple, or A/A. And then it is indole positive. And again, antibiotic susceptibility is needed for E. coli. Enterobacter, nosocomial infections again are common in the respiratory tract, UTIs, blood, and other sterile sites. Enterobacter is a late lactose fermenter. The colony may appear mucoidy, and biochemical testing is needed for this one. Again, susceptibility is also needed. Okay, we have Klebsiella. This one causes nosocomial infections again of the respiratory tract, UTIs, blood, and other sterile sites. Klebsiella is a lactose fermenter. Colony may be mucoid, and biochemical testing would be needed to identify Klebsiella. and again, an antibiotic susceptibility would be needed as well. Morganella, nosocomial infections, again, are common for Morganella, and Morganella is a non-lactose fermenter. What makes this one unique is it shows up as R over A in LIA, so it would be a red over yellow, and biochemical testing and susceptibility would be needed. Our Proteus species like to cause nosocomial infections as well. They are non-lactose fermenters, amaconchi. They smell very foul-smelling. They may swarm, so you'll kind of see ripples in the media. They are also R over A and Li, and they may produce H2S. Susceptibility would be needed for Proteus as well. Providentia, very common, or not common, but very similar to Proteus and Morganella. Again, causes nosocomial infections. It's a non-lactose fermenter. It shows up as R over A in LIA. Biochemical and susceptibility testing would be needed. Salmonella causes gastroenteritis, bacteremia, and typhoid fever. Lab tests for ID include it's a non-lactose fermenter. It can produce H2S. Will be K over A or A over A without gas and H2S in the TSI. It'll be K over K or purple over purple, or K over A, purple over yellow, with or without H2S in the LIA. Serotyping is also needed to identify which serotype of Salmonella is present. Antibiotic susceptibility might be possibly done. Supportive therapy is usually used to replace fluids lost from the diarrhea caused by Salmonella. Serratia causes nosocomial infections. It appears as a red colony on amaconchi agar, and biochemical and susceptibility testing are needed to identify. Next, we have Shigella. Shigella causes diarrhea and disease. It is a non-lactose fermenter. It is K over A with or without gas in TSI, and K over A in the LIA as well. Serotyping is needed to identify which serotype of Shigella it is. And again, susceptibility might possibly be done. More commonly, supportive therapy is used to replace the fluids lost from the diarrhea and dysentery. Yersinia pestis causes the bubonic and pneumonic plague. This also is a non-lactose fermenter. Yersinia likes to grow at colder temperatures, about 25 to 30 degrees. You will see a stalactite type pattern in broth cultures. So if you think of stalactites in caves, it looks very similar growing in a broth culture. And susceptibility usually is not needed, as streptomycin is the drug of choice. Another member of Yersinia to note is Yersinia enterocolitica. This one causes enterocolitis. It is screened for sometimes on stool cultures. And this is a non-lactose fermenter. In sin agar, you will see a bullseye colony, and anti-susceptibility is needed. Whew, that was a long list of Enterobacteriaceae. Now we're moving on to the other gram-neg rods. Okay, first we have Acinetobacter. This one causes nosocomial infections, respiratory tract and wound infections, and UTIs. It is oxidase negative, and susceptibility would be needed. Aeromonas causes gastroenteritis. It is oxidase positive and is a glucose fermenter. There are no guidelines really on susceptibility for this organism. Bordetella pertussis, whooping cough. It is grown on Bordei Gengao and Reagan Low media. It is non-modal, and PCR tests are available for this organism. Susceptibility usually isn't needed, as erythromycin, clarithromycin, or azithromycin are usually used to treat Bordetella pertussis. Fortunately, we do have a vaccine for pertussis. This one is very catchy, so it's transmitted through respiratory secretion. So if you have to draw a patient that is known to have whooping cough, you would want to wear a mask. Next, we have brucella, which is the causative agent of brucellosis. It is non-hemolytic oxidase positive, urea hydrolysis positive, and may produce H2S. Susceptibility on this organism is usually not done because it's not reliable. Campylobacter jejuni causes gastroenteritis. It is one of those organisms that we screen for in stool cultures. We can detect it by growing it on Campy blood agar and modified Scleromedia. Usually we incubate at 42 degrees Celsius. It is catalase positive, hippurate hydrolysis positive, and appears as seagull wings on the gram stain. Susceptibility is usually not performed. Now we have Eikenella corrodens. This one is commonly a cause of infections in bite wounds, neck infections, and can cause endocarditis. It is a member of the HASEC group. It's the E in the HASEC group. It does pit the agar, has a very characteristic bleach odor, and is oxidase positive. And you would want to do susceptibility on this organism. Next, we have Ficella tularensis, causative agent of tularemia. Lab tests include the requirement of cysteine and iron. It is catalase weak positive and oxidase negative. Susceptibility usually is not needed as the drug of choice is streptomycin. Haemophilus influenzae causes sinusitis, otitis media, bronchitis, and meningitis. This is one of our fastidious, picky organisms, so usually only will grow on chocolate agar. It has a mouse nest odor, requires X and V factor. Serotyping may be done on Haemophilus influenzae to detect which type it is, and susceptibility testing would be needed. One thing to note about Haemophilus influenzae is you might see some little tiny satellite colonies growing on blood agar if you have another organism that is there to produce the V factor. Our blood agar contains X factor because it's released from the red blood cells, but it does not contain V factor. So if you have an organism such as Staph aureus growing on the plate, you might see some little tiny satellite colonies of Haemophilus growing around it because aureus can produce that V factor for Haemophilus. Okay, next we have Helicobacter pylori. This one causes peptic ulcers, gastritis, and gastric carcinoma. It is motile, it's urease positive, oxidase positive, and catalase positive. You can do a urea breath test on a patient, and this can indicate, if it's a positive result, that the patient does indeed have Helicobacter pylori. You can also do IgG ELISA test or a rapid test kit for this. And susceptibility is necessary for this one. Next, we have Legionella pneumophilia. This is a causative agent of Legionnaire's disease. Requires L-cysteine and iron to grow. Likes to grow on BCYE agar. And we can do direct fluorescent antigen testing of the respiratory secretions. Susceptibility usually is not needed for Legionella. Then we have Pasteurella multocida. Causes some soft tissue infections following a bite or scratch, usually from a cat. This one is non-hemolytic, can have a mushroom smell to it. It's non-motile. It's oxidase positive and indole positive, but it is urease negative. And susceptibility may be possible. Usually the drug of choice is penicillin. Plesiomonas shigelloides causes gastroenteritis. It is oxidase positive, string test negative. This is one way that you can differentiate Plesiomonas from Vibrio cholera, is because Vibrio cholera is string test positive, whereas this one is string test negative. And there have been no definitive guidelines established for susceptibility of this one. Next, we have Pseudomonas venosa. This is an opportunistic pathogen. Nosocomial infections are caused just about everywhere in the body by this organism. Very characteristic blue-green metallic sheen on blood agar. Has a grape or corn taco odor, and it is oxidase positive. Susceptibility is necessary on this organism. Then we have Burkholderia capacia, causes respiratory tract infections and UTIs. It can be very life-threatening in patients that have cystic fibrosis. It is a non-lactose fermenter, has a dirt-like odor, and is oxidase positive. And there have been no definitive guidelines established for susceptibility testing for this organism. All right, next we have Cryptobacterium. This one can cause neonatal meningitis, pneumonia, wound infections, and UTIs. Characteristic of this organism is it is yellow on blood agar, it's oxidase positive, and it's also indole positive. And there have been no definitive guidelines established for this one. Next, we have Stenotrophomonas. This one causes catheter-related nosocomial infections as well as UTIs in patients. It is a nice lavender green to purple pigment on blood agar. Can have an ammonia smell, and it is oxidase negative. Susceptibility would be needed on this one. And finally, we have Vibrio cholera. This is the causative agent of cholera. Grows on TCBS. In motility, it has a darting or shooting star motility, and it is oxidase positive and string test positive. And susceptibility would be needed for Vibrio cholera. Also, supportive therapy to replace the fluids lost through the diarrhea is necessary. On the bottom there, I have a little reminder HASEC group. There's your components of the HASEC group. We have Haemophilus aerophilus. That's my favorite species because it rhymes. Then we have Actinobacillus, Actinomycetomicans, Cardiobacterium hominis, Eikenella corrodens, and Kingella species. The reason they're all grouped together like this is because they all cause endocarditis and they are all rods. Wow, that was a lot of gram-neg rods to remember. Like I said, that's probably the biggest group that you're going to have to study. But if you pay close attention to those tables that I gave you and memorize those key lab characteristics, it'll be pretty easy to differentiate between. All right, we're moving on to the gram-neg diplococci. There aren't very many of these, so these should be pretty easy to remember too as far as what their gram stain is going to be. You can see by the arrows there that we have two nice little diplococci there, kind of look like kidney bean shapes. So really the only ones we have to remember for gram-neg diplococci include our Neisseria species and our Moraxella cataralis. So Neisseria gonorrhea causes STDs, pelvic inflammatory disease, and can cause conjunctivitis. Grows on modified Sayre-Martin, Martin-Lewis, or New York City, and it is oxidase positive and glucose positive. Susceptibility would be necessary for Neisseria gonorrhoeae. Neisseria meningitidis is a causative agent of meningitis. It can be very life-threatening if a patient does get meningitis with this organism. There is a vaccine available to protect patients against meningitis caused by this organism. Grows on modified Sayre-Martin, is oxidase and glucose positive just like Neisseria gonorrhoeae, but the differentiating characteristic between these two is meningitidis is maltose positive as well. And serotyping is needed to figure out which type of Neisseria is causing the meningitis. Susceptibility would be necessary for this one. Now, an easy way for me to remember the lab results of Neisseria gonorrhoeae and Neisseria meningitidis is to think of glucose positive goes with gonorrhea. So you've got glucose and gonorrhea, two G's there. And with meningitidis, you've got maltose and meningitidis. So the two M's go together for positive. And if you want to add another one in that I don't have on this slide, we have Neisseria lactamica. That one is glucose, maltose, and lactose positive, and the two L's go together. So that's easy to kind of remember as you're studying. The M's and the G's go together. All right, and then finally we have Moraxella cataralis. This is also a gram-neg diplococci. It can cause otitis media, sinusitis, and pneumonia, and it's a characteristic hockey puck type colony. on chocolate agar. And what we mean by that is when you take your loop and you try to pick it up, it kind of slides across the plate. You can't really pick it up. And so it's just kind of like a hockey puck. You just kind of push it around on the media. It is oxidase positive, DNase positive, and it's asaccharolytic. And susceptibility usually not needed for this one. Okay, next we have the grandpa's rods. Here you can see the dipteroid type appearance, and usually kind of how I learned it is they look like V's or L shapes or little Chinese letters, and that's why they're called dipteroids. First we have Bacillus anthracis. This can cause cutaneous, pulmonary, and gastrointestinal anthrax. It's a large, gray, non-hemolytic, ground glass colony, also sometimes resembles a medusa head appearance. It is spore-forming. It's non-motile. It's sensitive to penicillin, and it is a wide zone of lecithinase on egg yolk agar. Susceptibility testing is performed in a reference lab only, and penicillin is usually the drug of choice. Bacillus cereus causes diarrhea and emetic food poisoning. Emetic meaning vomiting. Is beta hemolytic. It's spore forming. To differentiate it from Bacillus anthracis, it's resistant to penicillin, and then just like anthracis, it produces a wide zone of lecithinase on egg yolk agar. There have been really no definitive guidelines established for susceptibility. Corynebacterium diphtheriae causes respiratory and cutaneous diphtheria. It grows on cysteine tellurite blood agar and modified tin sales agar. You can detect a toxin production on the ELEC plate. It is catalase positive, it's non-motile, and it is gelatin and esculin negative. Antibiotic susceptibility is usually not needed, but an antitoxin must be given as well as either penicillin or erythromycin to treat this organism. Next we have Erysipelothryx ruthiopathii. This causes an erysipeloid. It is catalase negative, and it produces H2S in TSI. Susceptibility is not needed. Gardnerella vaginalis is causative agent of bacterial vaginosis. It's a small gray colony, produces a diffuse zone of beta hemolysis on blood agar. It is catalase negative, and it grows on HBT. And then you can see clue cells in wet mount of this organism. So you can have a wet mount of a vaginal secretion that has been taken from a patient, and sometimes you'll see these little bacteria sticking right on those epithelial cells, and that's what we term a clue cell. Susceptibility is not needed for this one. Lactobacillus is an opportunistic grandpa's rod. It is alpha hemolytic. It's catalase negative, and you can see chains of rods in a wet mount. This is often seen in a urine specimen or a vaginal secretion. Gardnerella vaginalis clue cells can also be seen in a urine specimen as well. Lactobacillus susceptibility is usually not needed, as most of the time it's a contaminant. Remember that lactobacillus is a normal flora organism in the female genital tract. Next, we have Listeria monocytogenes. This is a causative agent of neonatal meningitis and granulomatosis infantis septica, which means that if a mother has been infected with Listeria, babies or the fetus may be born stillborn because it is such a serious organism for these full patients. Colony resembles group B strep in that it's a beta hemolytic colony, kind of a clear grayish color. It is catalase positive. It's CAMP positive, has some tumbling motility in the hanging drop and an umbrella motility in the motility media. It is VP positive and esculin positive. Now I hear that it resembles group B strep because a lot of techs can mistake Listeria monocytogenes and group B strep because Listeria looks like group B strep on a plate, and it is CAMP positive. So if you miss those critical tests of doing a gram stain, which would differentiate the group B strep because it's a gram-poxy from the listeria, which is a gram-pos rod, and you forget to do the catalase, catalase is negative for the strep, where it's positive for listeria. Some techs can mistake the two. Susceptibility would be necessary, but testing is rarely needed to guide therapy for this one. Then we have nocardia. This one causes skin infections in immunocompetent patients, but it can cause some invasive pulmonary infections in immunocompromised patients. Nocardia is partially acid-fast, and susceptibility testing may be performed, but it's done at a reference lab. Streptomyces causes an actinomycetoma. It is partially acid-fast negative, and that's how you differentiate it from the nocardia. And susceptibility is usually not necessary. Standardized methods for this organism have not been available. Next, we have the anaerobes. I think kind of the basic thing that I want you to get out of the anaerobes is to be able to tell me which one is gram-pos rods or gram-pos coxy, which one are gram-neg rods and gram-neg coxy. So if you can remember the gram stain of the anaerobes, that's really good. And then what I'm going to do is I'm going to go through specimens that are acceptable, then I'm going to go through media that's used for anaerobes, and then we're just going to touch on some of the more common anaerobes that you might isolate. So here you can see we have our gram-pos rods that form spores. That's our Clostridium species. We have our non-spore-forming gram-pos rods. This includes Actinomyces, Bifidobacterium, Lactobacillus, Propionibacterium, and Eubacterium. Then we have our gram-pos coxy, which include Peptostreptococcus. We have our gram-neg rods, which include Bacteroides, Fusobacterium, Porphyromonas, and Prevotella. And then we have our gram-neg coxy, which includes Violinella species. Okay, pretty easy to remember what should be acceptable for an anaerobic culture and what is. If it's been exposed to air, it's not acceptable. If it hasn't been exposed to air, it is acceptable. So we have CSF, fluid from a sterile site, a biopsy of a tissue, and a material that's been aspirated from an abscess would all be acceptable specimens. However, if they've been exposed to air, like sputum, feces, throat swabs, nasopharyngeal swabs, vaginal swabs, urine, or eye cultures, they would not be acceptable for an anaerobic culture. Okay, we have our anaerobic media. I have grouped them into the non-selective and selective media. So under the non-selective, we could use an anaerobic blood agar, an egg yolk agar, chopped meat broth, peptone yeast extract glucose, and thioglycolate broth. All of these would be non-selective for your anaerobes. So most all of the anaerobes will grow on this media. Keep in mind you can use thioglycolate broth for aerobes as well. The aerobes would grow towards the top where the oxygen is, and anaerobes would grow towards the bottom. Our selective media includes BBE, which is selective for the Bacteroides fragilis group. We have LKV, which is selective for Prevotella and Bacteroides species. We have our anaerobic PEA, which inhibits the enteric gram-neg rods and swarming Clostridia. And then we have our CCFA, which is selective for C. difficile. Okay, quick review of some specific anaerobes. Pigmented Prevotella and Porphyromonas species fluoresce brick red. So there's a picture there for you to see under the UV light. They will fluoresce the brick red. That is one characteristic of these. Next, we have Fusobacterium nucleatum and Fusobacterium necrophorum. These ones are gram-neg rods with tapered ends. The picture is a little small, but you can see towards the ends of the bacteria, they do taper off to a point. Next, we have Bacteroides fragilis. This one is found in the intestine and gains access to normally sterile sites via trauma or surgery. It's probably the most commonly isolated anaerobe, and it grows on BBE and is resistant to kanamycin, vancomycin, and colistin. You can see on the right-hand side where that white arrow is, that's Bacillus growing on BBE. Next, we have our Clostridium species. Clostridium perfringens causes gas gangrene. The spores are subterminal or central, and Clostridium perfringens has a boxcar shape under the gram stain. Clostridium I causes tetanus or lockjaw. It has oval, terminal, or subterminal spores, often shaped like a tennis racket. Clostridium botulinum causes botulism. These spores are also shaped like a tennis racket and are usually subterminal. And then finally we have Clostridium difficile, which causes diarrhea. The spores on Clostridium difficile are subterminal and oval. All right, just a quick little fact about Clostridium perfringens. It has a double zone of beta hemolysis on anaerobic blood agar. So you can see that there, number 1, it's a little bit more of a clearing, and then number 2 there's a little bit less of a clearing around the colony, but there still is beta hemolysis. So that's a characteristic of Clostridium perfringens. All right, and then the last anaerobe I want to go over is Propionibacterium acnes. This is a gram-pos diphtheroid. It's associated with acne and is a frequent contaminant in blood cultures. Do you remember the other frequent contaminant in blood cultures? It's the staph epi, right? Our coagnatic staph is another common contaminant of blood cultures. Okay, last but not least, we have a review of mycobacteria. Some general characteristics of mycobacteria include these organisms have a high lipid content in their cell wall. They are acid-fast positive. They are slow growers. Some might show up at 2 days. Some might not show up until 60 days. So it's very common to hold these cultures for a long, long time. And then we have 2 groups of bacterium. We have the Mycobacterium tuberculosis complex, which causes tuberculosis, and then we have the non-tuberculosis mycobacteria groups, which do not cause tuberculosis. So I'm going to be going over just the common ones that are mentioned on your ASCP study guide. The picture there is an acid-fast stain Mycobacterium tuberculosis. Sometimes they say it looks a little bit like a Chinese dragon because it kind of ropes together. So that's kind of what you're seeing here is a positive acid-fast stain of TB. Okay, Mycobacterium tuberculosis complex. These are the organisms that are included in that complex. We have M. tuberculosis, bovis, bovis BCG, and africanum. Isolation is required when working with these organisms. An N95 mask needs to be worn at all times. Symptoms and signs include low-grade fevers, night sweats, fatigue, anorexia, weight loss, and a productive cough. All healthcare workers have to have a Mantoux test done at regular intervals. This is called a tuberculin skin test, or the PPD. You might hear it called. Stands for a purified protein derivative. The theory behind it is that an extract of M. tuberculosis is cutaneously injected, and if patients have been exposed to TB before, they will develop a delayed hypersensitivity reaction. And so the extract is put into the skin, usually the lower arm, and 48 or 72 hours later, it needs to be read for that delayed hypersensitivity reaction. Okay, our non-tuberculosis mycobacteria include all other species that I did not mention in the TB complex. They are present everywhere in the environment. and they can colonize healthy individuals in the skin, in the respiratory, and in the GI tracts. They're usually not transmitted from person to person, and you don't need isolation. However, when you are working in the T lab, you don't know whether it's TB or not TB, so you are going to be isolated no matter what species of mycobacteria you are working with. For the non-tuberculosis mycobacteria, there is what's called a Runyon classification. We have 1 through 4. Category 1 are photochromogens, and these are mycobacteria species that develop pigment when exposed to light. This includes Mycobacterium kansasii and marinum. Then we have category 2, which are the scotochromogens. These develop pigment in the light or the dark. This includes Mycobacterium gordonii and Scrofolaceum. Then we have category 3, photochromogens. These produce no pigment, whether they're in the light or not, and this includes Mycobacterium avium complex. And then finally, we have the rapid growers, which is category 4. Growth appears in less than 7 days and includes Mycobacterium fortuitum. So with the photochromogens, the scotochromogens, and the non-photochromogens, it's longer than 7 days for growth to appear, whereas if it grows in less than 7 days, they're clumped into the rapid growers category. All right, our photochromogens here include Mycobacterium kansasii and marinum. Kansasii is found in tap water and causes chronic pulmonary disease. Marinum is found in freshwater and saltwater and causes cutaneous disease and bacteremia. So you can think of marinum, kind of marine, so you think of freshwater and saltwater. Then we have our scotochromogens, which include Scrofolaceum and gordonii. Mycobacterium scrofolaceum is found in raw milk, in soil, in water, and dairy products. So you can kind of think of that as being pretty much everywhere. And can include infections in the pulmonary system, skin infections, cervical adenitis in children, and also bacteremia. And Mycobacterium gordonii is found in tap water, in other water, and soil. And this one is rarely pathogenic. Then we have our non-photochromogens, which includes our Mycobacterium avium complex. This is found in the environment pretty much everywhere, including water and soil. Causes pulmonary infections, cervical lymphadenitis, and in AIDS patients, it can be more severe and cause disseminated disease. On the bottom there, you can see Mycobacterium avium complex includes Mycobacterium avium, intracellular, paratuberculosis, lepramurium, and wood pigeon bacillus. Avium and intracellular are the only ones that we're really concerned about in the clinical lab. And finally, we have our rapid growers. We have Mycobacterium fortuitum. This can cause postoperative infections, soft tissue infections, and pulmonary infections. Then we have our Mycobacterium leprae. This is a non-tuberculosis mycobacterium, and this is a causative agent of leprosy. It's also called Hansen's disease. It causes a chronic disease in the skin and mucous membranes and the nervous tissue. It has not been cultivated in vitro. The only place that they've been able to cultivate leprae is in the foot pads of mice and an armadillo. So it's not been able to be cultivated in vitro. PCR can be used to detect and identify, but most of the time they look at the signs and symptoms of the patient to diagnose. Lab diagnosis of mycobacteria include direct detection using the acid-fast stain. The acid-fast stain targets the mycolic acid in the cell wall. You can use a fluorochrome stain, so it would be a fluorescent type stain. You can also use the Zeal-Nielsen or the Kinune acid-fast stains. And then you can culture them using Middlebrook 7H10 or Lowenstein-Jennings media. Okay, we're done with our bacteria review. I hope you were able to through that. I know it's a lot of stuff. Here's a couple things I want you to remember. All organisms that I have covered in this review are listed in your ASCP examination content guidelines for your MLT board. So make sure you are studying this PowerPoint and going over this WIMBA session. That will help you to review. Note that it's not a comprehensive review. You should be going over your study guides from Micro 1 and 2, looking over your PowerPoints, using all of that information as well. Keep in mind to always follow your own laboratory protocol. I have done my WIMBA session here and put together these notes for you from my own experience and from the textbook. And so, again, every laboratory is different in regards to the protocol that they use to work up each organism. So my instructors used to always say, when in Rome, do as the Romans, meaning when in your lab, do as your lab does. Okay, so follow your own laboratory protocol. All right, and then the last two, study, and if you think you've studied enough, you better do some more. Good luck on your boards, and I'm just an email away. If you need to ask me any microbiology questions, please feel free to do so. My email is Laura, LAURA.mastel, MASTEL, @rasmussen.edu. Good luck.